We're going to be moving into the iliopsoas muscle group, and specifically we're going to be focusing on right now is the psoas major. So let's review the origins and insertions for that muscle. We know it comes off the bodies of L1 through 5 as well as the transverse process, and then it then runs down and connects to the lesser trochanter of the femur. Its main actions are going to be hip flexion as well as lateral rotation of the thigh. And let's start off with a palpation of this muscle. Because it's lying very deep in the abdominal cavity, it's best if you get the patient to bend both knees. This will just take some of the slack out of the abdominals, which is going to be specifically important in a patient like this because he has very well-defined abdomen. Now what I'm going to do is I just mark the ASIS, and I know that muscle is kind of running sort of from the midline on a downward diagonal to the lesser trochanter. And now what I'm going to do is just slowly load in and weave through his intestines so I can get deep to them and come right up against the edge of the psoas major. When I feel like I've sunk as far as I can go, I'm going to remove one hand while holding the other. I'll get him to push up into my hand a little bit with his knee hard, nice and hard. And I can feel the muscle contract, relax there, right beneath my fingertips, so then I know I'm on that muscle. If I wanted to move up a little bit higher and a little more medial, again, I'm just going to slowly sink in through the tissues, checking in with the patient and make sure that feels all right. And then when you've gone deep enough, good, push up into my hand. And again, you can feel those fibers contracting directly beneath my fingertips, and relax. Slowly come out. For the muscle test, what we're going to do is straighten both legs. So I already mentioned it's a hip flexor as well as a lateral rotator. So you're going to want to be slightly in that position. You're going to bring the hip up to about 60 degrees, bring it out just a bit, and then toes out or laterally rotate the thigh. You really want to make sure you have a soft but firm supportive contact across the ASIS on the other side, because as you apply force on your muscle test, it's going to tip their body if you don't. So hold there nice and strong. This is challenging mostly the upper fibers of psoas major, and we can slowly work down the muscle by just working him outwards and reorienting our line of drive while we do this muscle test. Hold there, nice and strong. And then one last one. Very important on these last few that you're doing counterbalance with your support hand. Otherwise, they'll feel like they're going to tip off the table during the muscle test. With the patient in the test position, you can see by orientation of the limb that it's actually going to challenge the fibers a little bit higher on the psoas major. But then as I move his limb out, it's now reorienting the fibers a little bit down, and then again more, until you get all the way out here. And now this is sort of like an L5 test position, L4, L3, L2, and L1. So you can kind of work through the entire range of motion of that muscle, checking all origin and insertion points. If you're unsure if it's a specific iliopsoas injury or not, keep in mind this is going to challenge some of the muscles of the groin as well. You can see the adductors are firing when we do this muscle test, but because the limb is in this position, it's being most specific to the iliopsoas specifically, as well as the psoas major. So if symptoms are higher up, it's pointing you more towards involvement of this muscle. If they're perhaps feeling pain or discomfort down low, you might want to then move into some specific muscle tests for the adductor muscle group.
So, as I was saying, we're going to go ahead and look at the iliopsoas on this fantastic working model that we have right here, where you can see the clear origination points all the way up. Elastic fibers have been ran down to represent all of the psoas major muscle fibers to the lesser trochanter. If we look on a base level, anatomical understanding here, leg in neutral position, we can see that the psoas has to wrap around the front of the anterior pubic ramus there and flow back, and the main fiber pull is actually going to be for hip flexion. So you can see flexion up, flexion down. If we bring it more into plane, flexion up, flexion down. Other key actions for psoas, though, include lumbar stabilization. And in fact, this model clearly shows you that if you were going into extension of the low back, the psoas major would be acting as guy wires to hold you in position from going further back into extension. Conversely, if your legs stayed where they were and you did an anterior pelvic tilt, the psoas fibers would pull you more into extension or hyperlordosis. So, super cool model. I'd encourage you all to go ahead and try and make this up yourself. Easy for you to see the fiber direction and action of iliopsoas and relationship to how you might actually palpate it as well, as you saw previously in the video, sinking through the soft tissues in this region. All right, so for basic orientation again, where do we start? We can see the sacrum down here, the cauda equina, spinal cord all through here, intervertebral discs, So this makes this L5, L4, L3, L2, L1 with its associated compression fracture that we talked about before. If we can flip this up, what you'll see is a better outline of iliopsoas. So this is all of the psoas coming up, psoas major. Okay, iliacus portion is up here in the iliac wing. This right here actually, let's start there, is psoas minor. This is the diaphragm. A lot of people are surprised how thin the diaphragm actually is. Very thin muscle. It is your primary muscle of respiration. We don't usually talk too much about this, but the diaphragm actually connects directly to the iliopsoas, all right? There are fascial bands over top of it, but when you're looking at different yoga poses or difficulty breathing or tight hip flexors, we could make an argument for a connection between the psoas major and the diaphragm influencing function, or the opposite way around, the diaphragm potentially influencing some of the function of iliopsoas and its origination points off of the vertebral bodies there. This is psoas major as it comes down, so just look at the size of that muscle. This is again a 28-year-old male, so a very healthy sized psoas coming down, and iliacus all the way through here. So a lot of our treatments that we're doing are involved in reaching in around the ASIS, this area here, working through iliacus, also potentially working into the psoas major muscle. Pretty neat for us to see. So ASIS is right there, and you can trace across the inguinal ligament. This is the spermatic cord as it comes down to the testis right there. And of course the basic muscles around the hip like sartorius, TFL, all that good stuff. This is the femoral triangle right here, so we can see that common iliac artery that divided into the external iliac artery reappearing here as the femoral artery.